Hello, and thank you for this opportunity. Allow me to share my slides. My name is Sameer Sheth, and I'm very happy to talk to you today about deep brain stimulation for treatment-resistant depression. This is a topic that is very near and dear to my heart, and I'm very happy to share it with you, and thank you for your attention. A few disclosures: the consulting agreements are not really relevant, nor is the fellowship funding. Funding from NIH, that first one in bold, I will be talking about in the latter part of this talk. And deep brain stimulation for depression is off-label in the United States, and so this is investigational. I'll start with some propositions I'd like to discuss with you all. The first and really most important is that mental health disorders affect brain networks, and therefore they demand network-minded therapy. There's no single spot in the brain that is the locus for depression or OCD or any other psychiatric or mental health disorder. And I think that future efforts in neuromodulation, certainly surgical neuromodulation, will rely on improved methods of identifying and engaging these networks in a disorder-specific and individual-specific way in order to really optimize therapy. This is a brief outline. I'll talk first about the historical background of DBS for treatment-resistant depression to get us all on the same page. Then I'll talk about depression networks, and this discussion will kind of motivate the last part of the talk, which is on future efforts to optimize and individualize DBS for depression using this network-based understanding. So first, as a background, DBS for depression has been around for many years. As I said, it is investigational in the United States. There are several targets undergoing active investigation: the ventral capsule ventral striatum, the subcallosal cingulate or area 25, the superolateral branch, the medial forebrain bundle, and other associated nomenclature for this target, lateral habenula, and many others. I'm going to focus on the first two, the ventral capsule ventral striatum target and the subcallosal or subgenual cingulate. The VCVS target has been under investigation for a number of years. This is the first and seminal publication from Don Malone and colleagues in 2009. 15 patients in this open label series from 3 sites: Cleveland Clinic, Brown, Mass General. These are patients with chronic and treatment-resistant depression. They must have tried, of course, non-surgical therapy, including a number of medication trials and behavioral therapy, and oftentimes electroconvulsive therapy, which of course is definitely a requirement for trials these days. The results are summarized quickly here. I'll just point you to the figure in the lower right showing improvement in both the MADRS and Hamilton scores over time, over months. And basically the response rate, which was defined as a 50% reduction in the symptom score, was 40% at 6 months and just over half at 53% at last follow-up. So quite a significant response in these patients who are otherwise quite resistant. A remission rate of 20% at 6 months and 40% at last follow-up. Some adverse events of hypomania, which is definitely an adverse event associated with this target. Those promising results led to a double-blind, sham-controlled, randomized clinical trial that was industry-sponsored called RECLAIM. The plan was to enroll 208 patients based on their power analysis. This was done at the 5 sites shown here. There was an interim analysis that was unplanned after 30 patients were enrolled, and I'll talk to you about that in a minute. The design is shown here. The implant was done, and then about a month later, patients were randomized to 16 weeks of either active stimulation or sham stimulation, followed by an open label optimization, an open label period at the end. And these are the results. The sham response rate was 2 out of 14 or 14%. This was not unexpected, but the active response rate was only 20%, and this was unexpectedly low. This was done at this interim analysis that was not initially planned, but done after 30 patients were involved or enrolled. The difference between the active and sham was not significant, but of course there was not planned power to detect that difference. And the open label results are shown here, also quite modest. Considerations about this trial, as I mentioned, it was not powered to see a difference at just 30 patients, and perhaps that 4-month, 16-week period of time was insufficient to really be able to see a difference in response between active and sham stimulation. As well, the amount of exploration of the stimulation parameter space was quite limited during that double-blind, that randomized phase. They essentially used parameters borrowed from the movement disorders literature. It's unclear whether for any individual patient those parameters would be optimal. Lessons learned from this trial: should that double-blinded phase be longer? Should we allow more time for active versus sham to separate? Should the structure be different? Should patients be randomized right away to active versus sham? Do we know enough what stimulation parameters engage the appropriate networks to treat patients on an individual basis, such that we can go right away to a randomized format right after implant? And what about the variability in anatomy and in function that is now understood and appreciated to be quite important for individualized targeting? That was not used in this trial, and perhaps that would have changed the outcome. Interestingly, right around the same time, published around the same year, was this trial from the Dutch group with Damian Danis as the psychiatrist, Rick Sherman as the neurosurgeon. 25 patients, also open label initially, but with a very different design, where after implant of the device, they underwent about a year of optimization, open label optimization, exploring different stimulation parameters to identify those that may be optimal for each individual patient. Again, with the understanding that we don't necessarily know what that is yet for this target and for this indication. After that optimization, they were randomized in a crossover fashion to on versus off stimulation to provide some information about actual efficacy. The results shown here were quite different than Reclaim. After the open label optimization, 40% of patients responded, again with a 50% reduction in score. And during the double-blind crossover phase, there was a 56% responder rate. And this is shown here. The higher scores, of course, are worse symptoms. So during sham stimulation, their scores are higher. During active stimulation, they are lower. And this was a significant difference. So this trial, as opposed to the Reclaim trial, even though the target in the brain was the same, provided a very different and higher level of evidence, perhaps because of the different trial design. This open label optimization allowed stimulation parameter exploration, allowed individualization of that stimulation delivery. And this delayed crossover phase after the optimization allowed distinction of active effect from sham or placebo effect. So I'll switch gears here and talk about the other target, the subcallosal or subgenual cingulate. This target was really focused on, after the results of some neuroimaging work from Helen Mayberg and colleagues in the late 1990s. They did some O15 labeled water PET studies and showed that this part of the brain, this subcallosal area of the brain, had different blood flow depending upon whether patients were depressed or were healthy volunteers. They, along with Andres Lozano, the neurosurgeon at Toronto, implanted electrodes in this region in this initial pilot study in 6 patients in an open label fashion, a responder rate in 4 out of 6 patients, and PET studies showing normalization or change in that blood flow pattern reflecting improvement in symptoms. The continuation study in another 14 patients, total of 20, is shown here, published by Lozano and colleagues in 2008. Responder rate of 60% at 6 months, again, taking the same treatment refractory type of population with an almost 50%, 48% reduction in their Hamilton scores. Further open label work was done then by the Emory group with Bob Gross and Helen Mayberg, as well as this multi-center Canadian study. Results varied: a 92% responder rate in the Emory study, a 29% responder rate in the Canadian study. So some variability, but overall enough optimism to lead to this industry-sponsored sham-controlled randomized double-blinded trial known as Broaden. Planned enrollment was again just over 200, similar to Reclaim. Here there was a planned interim analysis after about half, or 90 patients were enrolled. The design is shown here, similar to Reclaim. Soon after the implant, patients were randomized to active versus sham stimulation in a double-blinded fashion. And again, strict restrictions of programming parameters during that double-blinded randomized phase. The results here in the double-blind phase are unfortunately much like Reclaim, in that there was a sham response rate of 17%. Compare that to 14% in Reclaim, very similar and expected. Again, the active response rate, only 20%, also very similar to Reclaim, but much below expectations based on the open label trials that preceded Broaden. There was a planned futility analysis that was performed at this point, again, after 90 were enrolled. And the futility analysis showed a 17% chance of seeing active versus sham separation if the trial were continued. The predetermined cutoff for discontinuation was less than 10%. So if that futility analysis showed less than 10% chance, the plan was to stop the study. It was not less than 10, it was 17, but nonetheless, the sponsor did decide to discontinue the study. Interestingly, the open label follow-up did show improved response in about half of patients. Interestingly, during the time of Broaden, there were advances being made in terms of how to do the DBS targeting and how to individualize that targeting to specific patients using white matter imaging and diffuser tensor imaging tractography. The story really was that if you just looked at responders and non-responders, there's quite a lot of overlap between those recording sites. If you just looked anatomically or at stereotactic coordinates, this is a paper by Clement Hamani and colleagues in 2009. On the other hand, if you look at the white matter connectivity, you look at the difference in connectivity profile between responders and non-responders, an interesting story emerges, which is that responders have a particular pattern of connectivity that non-responders do not have. And so then the idea was that perhaps if the targeting were refined such that the target were placed in a specific white matter confluence, that results may be improved. And indeed, as Ripapase and colleagues showed in their papers in 2017 and 2020, that is indeed the case, even in a prospective fashion. This evolution in targeting and individualization based on networks and white matter connectivity was not included in Broaden because the trial parameters were set before these findings were really well known. So lessons learned from all of these studies in VCVS and in subcallosal cingulate, some patients clearly improved. When batteries ran out of energy in an unknown or unpredicted way, patients definitely worsened. This is essentially a triple-blind study in terms of a discontinuity of care. So some patients definitely improved. Responses were certainly heterogeneous, though. And one thing that really characterized both of the pivotal trials that were stopped and unsuccessful was that parameter exploration was very much limited. And so the question really remains as to how to individualize and optimize engagement of a brain network on an individual patient basis. Okay, so this brings us to the middle chunk of this talk, talking about networks underlying depression and how we need to engage them and how we may be able to do so. So if we just zoom out and think about this, a network-based understanding of mental health disorders, we can come up with a few different concepts. First, as I mentioned in the very beginning, these disorders are disorders of brain networks, not of individual spots in the brain. As well, our classification based on symptoms is quite limited. For depression, for example, there are several criteria. You need 5 out of 9 criteria to be classified as having major depressive disorder. So you can have 2 patients with only 1 overlapping criterion that are given the same label, the same diagnosis. And as we know, just from our own experience, depression can look very different from one patient to the next. Now, instead of using the symptom-based classification, what if we could orthogonalize dysfunction onto axes that are defined neurobiologically based on circuit dysfunction? Doing so may actually provide a symptom domain-based way of classifying and therefore testing therapeutics, classifying the disorder and testing therapeutics, as opposed to this symptom-based way, which is imprecise and hard to generalize. And finally, we have the tools to do this. So the idea is that the network underlying depression or regulating mood, cognition, et cetera, may be represented by this wagon wheel where many different cortical and subcortical areas are on the outside of this wheel. And these are all areas that are involved in depression. The challenge is to find a central hub-like area where if we deliver stimulation or energy into this central hub-like area, the effective stimulation may be able to propagate along the connections between these areas, like along the spokes of this wheel, to engage a much larger region. And so that we can precisely target one region in the brain, but the influence of that stimulation may engage a much wider network that can be therapeutic. So how do we understand, engage, identify these networks? Well, we can certainly use non-invasive brain imaging techniques. This is resting state fMRI. This is one of the earlier papers from 2005 from Dr. Rakel and colleagues with Mike Fox that really started using resting state fMRI to understand networks. The idea is that the brain is not doing all the same thing at the same time. Of course, there's different regions of the brain that are coordinated and are coordinating to allow certain activities to occur. And we can use these fluctuations in the bold fMRI signal response to identify these different brain regions. This occurs at rest. This also occurs during tasks. Again, we see that brain regions that are working together have this certain profile with bold fMRI, so we can identify them. How do we use this for depression? Well, here's a monograph by Leanne Williams at Stanford that proposes one way of doing this. Her proposal is that, of course, we know that there are different networks identified by bold resting state fMRI. For example, the default mode network engages these areas of the brain, the intermedial prefrontal cortex, the posterior cingulate cortex, et cetera. The salience network includes the dorsal anterior cingulate cortex, areas of the insula, et cetera. Other networks involve these other brain regions. It could be that these different networks form kind of a structural skeleton upon which different types of depression may be manifest. So for example, the rumination type of depression may exist in and preferentially engage areas within the default mode network. The anxious avoidance network, type of depression, or biotype of depression, may engage the salience network, et cetera. And so these different biotypes of depression, rumination, anxious avoidance, cognitive dyscontrol, anhedonia, et cetera, may involve and engage these brain regions in a differential way. And we can use our understanding of these networks to study the differences between these depression biotypes. Okay, so now armed with this information, where can we go from here? So I will first talk about a study that we are doing, and this is an NIH Brain Initiative funded study that involves 2 clinical sites, us here at Baylor, as well as the site at UT Southwestern in Dallas. I'm the contact PI of this study, and my co-PIs are Nader Paratian, the chair of neurosurgery at UT Southwestern, and Wayne Goodman, chair of psychiatry here at Baylor. These are the 2 clinical sites. We have several other sites involved in some of the analysis and engineering, the devices. Duke University with Cameron McIntyre and his group are also involved in some interesting imaging studies that I'll show you. So the idea for this study that I'll talk about is to borrow what we know from another world, which is the epilepsy world. So some of you may know in the world of epilepsy, it's very common that despite a lot of non-invasive tests, video EEG, MRI, PET, MEG, SPECT, neuropsychological testing, WADA tests, et cetera, we're unable to identify the seizure onset zone just from these non-invasive tests. And so it's very common worldwide to implant electrodes within the brain, keep the patient in the epilepsy monitoring unit for days or a week or more to identify where seizures are coming from and study that individual patient's epilepsy network. So this model of using intracranial recording and stimulation to understand an individualized network, in this case epilepsy, is very common to epilepsy surgery, but is almost not entirely used outside of the epilepsy world. So the question is, can we borrow this approach of intracranial recording and stimulation to understand the networks underlying depression? As we do so, we are also using DBS technology that has segmented leads and steerable current, so we can orient the electrical field up and down the lead and circumferentially around the lead. And so with the DBS electrode just in one area, we can engage different networks by pointing the electrical field in different directions, as shown in the image here. So this is what the implant looks like for these patients in this trial. We have 2 types of electrodes that we're implanting. We have stereo EEG electrodes that are temporary and used for recording purposes mostly, and then DBS electrodes that are permanent and used for stimulating purposes. The DBS electrodes are placed in the 2 areas that I have spent the first half of the talk talking about, the subgenual cingulate and the VCVS. That's done bilaterally, so there's 4 DBS leads. In this first surgery, we also implant approximately 5 stereo EEG electrodes per hemisphere, and these are implanted in regions of the brain that we think are important in depression, that are regions of the brain underlying the processing of emotions, cognition, decision-making, et cetera. Dorsolateral PFC, ventromedial PFC, medial and lateral orbitofrontal cortex, cingulate cortex, mesial temporal lobe, including amygdala. These are all regions, again, from years and decades of non-invasive imaging and other studies we know are involved in depression. So this is what the overall trial design looks like. Patients initially get implanted with the electrodes I showed you previously, 4 DBS electrodes, 10 temporary stereo EEG electrodes. They stay in the hospital in the epilepsy monitoring unit for a period of 10 days. During this time, we do a number of studies to understand these patients' networks on an individual basis and how they respond to stimulation. At the end of that monitoring phase, the SEG electrodes are removed, the DBS electrodes are internalized to pulse generators, and then the patient undergoes an outpatient clinical trial where we start with 8 months of open label optimization, where we use the information gained from the inpatient phase to inform the programming of the DBS device to narrow down the massive parameter space to just a few sets of stimulation parameters that we think, based on the electrophysiological analyses, are going to be most relevant, most therapeutic. That's done in an open label fashion. And then, like one of the studies I showed you earlier, we then withdraw the stimulation in a randomized and double-blinded way to assess for efficacy. I'll just make a note as a sidebar that the planning for how to put these 4 stimulating electrodes and 10 recording electrodes into the brain requires real 3-dimensional understanding, which is quite hard to do on our traditional surgical 2D planning screen. So I'm going to show you a video of what we're using, developed by Cameron McIntyre, shown here, who's now at Duke. This is an augmented reality holographic system that allows us to really individualize and visualize the DBS sites as well as the recording sites and the connections between them. So this is done, as I mentioned, in this holographic augmented reality system. You can see how we can do this in a real-time fashion. We can import the patient's imaging on an individualized basis, and then in a very collaborative fashion, we can plan with this 3-dimensional appreciation, and we can move the electrodes, we can change the stimulation field models, and we can understand how all these different changes influence what regions of the brain are going to be stimulated from, how they're going to be recorded, and we can plan this implant in a 3-dimensional way in a very collaborative fashion. This is how we did this for the first patient in the trial, who's now 2 years into it. This was done in March of 2020. This is pre-pandemic, just pre-pandemic. And then now, this is actually also a very pandemic-friendly way of doing planning. This is planning for the last couple of cases, done all virtually and remotely. So this is, top left, this is me in my home with the augmented reality system. Nader Pratian, Kelly Bajanki, and others, Cameron McIntyre, Angela, all working, in their respective, homes or places of work around the country. We can do this collaboratively, simultaneously with 3D audio, so we can talk to each other, show each other what we're looking at, and really plan this implant in a 3-dimensional way. This really revolutionized, I think, how we were able to plan the surgery, and I think is going to be very important for neurosurgery in general. So our first case in this trial, as I mentioned, was done in March of 2020, just prior to the pandemic. We identified a few goals that we had for the case. 2 large goals. One is to measure the network state, meaning the electrophysiological or neural state in a few different conditions, at baseline or at rest, as well as across a few different emotional states, happy, sad, etc., using tasks to modify or influence that emotional state, as well as during various cognitive tasks. Secondly, we wanted to measure that network state in response to stimulation across a wide range of parameter space. I mentioned that the limitation of stimulation parameter space is one major limitation of some of those 2 large pivotal trials. So we really wanted to broaden this parameter space and measure it quite broadly and look at the network response to stimulation across that broad space. And finally, putting these 2 things together, how does the brain encode happy versus sad, to simplify, and how does the brain respond to stimulation? If we put those 2 things together, we can then say, well, here's the state that we want. Here's how stimulation affects brain state. So we can then choose the stimulation parameters that are likely to produce the network response that leads to the symptom response that we're trying to target. This is just some pictures of that first case. Again, quite a team that was assembled to do so. A long surgery and then 9 days of experiments afterwards. Lots of data generated. Many experiments were conducted. 1,600 or more parameter combinations were tried. Again, a massive team led to this effort and were instrumental to getting it to be successful. This just shows a schematic of the implant. The DBS leads are shown here with the cyan blue and kind of pink contacts. And then all the other colored contacts represent the stereo EEG electrodes across the wide network. Again, sampling all these different regions of the brain: cingulate cortex, amygdala, prefrontal cortex, ventromedial, dorsolateral, etc. And so we have access to a wide range of these regions in prefrontal and temporal regions. Visualizing and understanding these data is quite a challenge. You can imagine. This is a video done by Raisa Mathura, my research coordinator. You can see how complex this is. So during, for example, left SCC stimulation, this is the pattern of activity evoked just in high gamma, for example. When we stimulate right SCC with one particular parameter combination, we get this other pattern. Here's left VCVS, creates yet a third pattern of activity across this network. And then finally, the right VCVS with certain parameter stimulation produce this pattern of activity. These patterns are quite different for each stimulation combination that is provided to the brain, and so it just creates a massive data set and it's high dimensional. And so studying these data and analyzing them is quite a challenge. As well, we stimulated across, as I said, a wide range of frequency parameters, pulse width, amplitudes, and contact configurations across a wide duration of stimulation, from individual single pulses to 1 second stimulation, 15-second, and longer durations. At the short frequency, at the short durations of stimulation, we're able to test across a wide range of parameter space. With longer duration of stimulation, of course, that parameter space had to be reduced. We're able to sample quite a few combinations with this approach. And so now, to really generate these electrophysiologically or network-defined stimulation parameters, we created this schematic to illustrate this complex problem. So the clinician, the programmer, has control over the input stimulation parameters. So for example, the frequency, the pulse width, the amplitude, the direction, which lead you're using, et cetera. These are the parameters that we have control over as the clinicians. We, the typical way of doing this is that we, through a trial and error fashion, use and employ some set of stimulation parameters, and then something complex happens in the brain that's difficult to understand, and then there's some behavior. The patient is improved or patient is not improved. Okay, and what's happening in the middle? Well, we don't know in traditional DBS, but with this approach, with the intracranial recordings, we do have a window into what is happening within the brain. So we can understand and calculate this network state, which is the spatial and spectral changes occurring in the LFP at each of these contacts, of which we have more than 150 throughout the frontal lobe and temporal lobe. And so now we can try to solve this complex problem by saying, okay, here's the behavior that we would like to target. Here's the network state associated with that behavior. And so now here are the input parameters that generate the network state that produces this desired behavior. There's many ways of doing this. Our first attempt in our first patient is shown here. This is the work of Kelly Bajanki, who's faculty in our department, as well as her postdoc, Brian Metzger. So here's what they did. They said, okay, well, here's a desired state. Here's a desired set of LFP features across this frontotemporal network. How do we define that? There's a few ways of doing it, a few ways that we did it. The patient's overall emotional and cognitive state on day 9 of his stay was much better than it was before, and we defined this as the desired state. We also did it a couple other ways, which are described in the paper. And then secondly, we said, okay, for each stimulation configuration, here's the pattern of activity produced by the brain. So here's the desired state. Here are many different states produced by all the different stimulation parameters shown. And then we use this iterative general linear model to say, okay, which input parameter state produces a pattern that most closely resembles the desired state? Again, many ways of doing this. And this is the one that we implemented first. These are the stimulation parameters that were generated based on that modeling approach. All the numbers in blue represent things that are different from parameters defined just purely by behavioral testing and seeing what made the patient acutely better or worse. That trial and error approach is fraught with concern because of the massive amount of stimulation space to explore and the unclear relationship between an acute response and a long-term response. So this electrophysiologically defined response, defined set of stimulation parameters may be one way to objectively do this. These are the results from our first patient. This was published just a few months ago last year in 2021. I'll call your attention to the blue line, which is the Hamilton Depression Inventory, and the orange line, which is the MADRS. The yellow bar here is the week and a half within the epilepsy monitoring unit, the inpatient phase. And then this pink bar is the outpatient phase, where we used the information gained from the inpatient phase to design just a few stimulation parameter combinations to try. We're not trying to massively explore the space. We did that in the 10 days in the hospital. And so this, of course, shows the improvement over time. The dashed line represents remission criteria, both for Madras in orange and Hamilton in blue. So by about 4 months into the outpatient phase, the scores dropped to a point that was in the remission category and continued to decline. This is all done open label. And then at this point, as I mentioned before, there was the double-blinded randomized withdrawal phase, where we started to reduce stimulation amplitude in a double-blind fashion. The dark blue bar here shows 100%. So there was a period of a couple of weeks where we did not make any change, and there was no change here, indicating a lack of any nocebo effect. And then again, in a blinded fashion, we started to incrementally reduce stimulation amplitude by 25% every week. The patient was unaware of this, and the symptoms started worsening until they met escape criteria, at which point we reinstated stimulation now after breaking the blind in an open label fashion, and the patient again got better. So this worsening of symptoms during withdrawal in a double-blinded fashion, again, speaks to the likely efficacy and distinguishment from any sham or placebo effect. The top here again shows that publication, which came out last year. And I'll mention a related publication from the UCSF group, Catherine Skangos, the psychiatrist, Eddie Chang, the surgeon, as well as Phil Starr, the neurosurgeon at UCSF, is also published last year using a similar approach, using stereo EEG recordings in the brain to define targets in a slightly different second part of that, where they used a responsive neurostimulation system to record from and stimulate the brain chronically, and also with good response. So I'll just summarize and wrap up here. Network disorders such as depression, OCD, many other psychiatric or mental health disorders demand a network-based therapy. We can't just focus on individual spots in the brain. We have to think of the brain as a network, and how do we engage it effectively and on an individual specific basis. Intracranial recordings, as I've shown here, and other groups have also started to show, provide a unique perspective into this network activity and the effect of stimulation on this network. And in the future, I really do think that individualization of both imaging and electrophysiological analyses will hopefully drive improved outcomes. I mentioned many members of the team along the way. These are pictures of more of the team. It's a massive effort here, and the other groups that are doing this kind of work. I really want to thank them because they are completely instrumental and just demonstrate how team science can be brought to psychiatric neuromodulation. With that, I will say thank you for your attention. I'll stop my share, and I'll say thank you once again.